Ma'am, you are giving me goosebumps on selecting the station.
Just a minute, just a minute. Yes, it is actually a goosebump station.
No worries, ma'am. No worries. Any surprise is welcome.
Yes, I
Aparna,
have
you are
already told you
already
I'm coming with
completely prepared for
surprises,
your
right?
exam. So, ma'am is actually checking you.
Don't worry, just few in I'm preparing for becoming examiner. So just wait for my arrival. Okay, all right. So let's start. Your 2 minutes start right now. Please, Aparna, you are doing right.
Yeah, ma'am. Ma'am, my slide has not yet changed. Okay, done. Next slide, ma'am. Next slide, ma'am.
How many slides you want? These are 2 slides.
Yes. I'm ready, ma'am.
Okay, start. Please, someone note the timer. Please, can somebody start the timer?
Yes, ma'am. I will.
Okay.
Okay. Hello, I'm Dr. Aparna, ST5 in the Gynae Clinic. May I confirm your name and age, please?
Yeah, doctor, I'm Phoebe. I'm 48 years.
How can I call you?
Phoebe is okay?
Okay. Phoebe, I can see from your letter that you have certain concerning symptoms. Is that correct?
Yes, exactly.
Okay. Any other expectations from today's meeting apart from discussing those?
No, these are actually bothering me, so I want to discuss about those.
Mm, okay. Phoebe, as we are meeting for the first time, is it okay if I ask you a couple of questions to address your concerns better? And in the end, I will be providing you the written information leaflet, documenting whatever we are discussing, and with permission would write back to your GP. Is it okay with you?
Yeah, exactly, sure.
Yeah, thank you so much. So, Phoebe, can you tell me more about your concerns?
Yes, doctor. Actually, it's been from last 6 to 8 months that I'm having
Mhm.
some disturbing symptoms. Like at the night, I feel like I'm just suddenly I become so sweaty, and I'm having some hot flashes. So I just wake up and I switch on fan, and I was all sweaty. So these are very new things for me. I don't know why it is happening with me.
It's indeed a difficult time for you, Phoebe. So, how are you coping up? Are you taking any medications or any cool baths, anything like that?
Yeah, my GP has actually told me that I should stay in a cold room, and I should wear some cotton clothing. So all these things he has actually told me, but I think so they're not working for me exactly.
Okay, I can see that. Okay, and do you have any bone pains?
No,
Any dryness down below?
not much, but yes, there is some a little bit you can say.
And what about, are you able to sleep in the night perfectly?
No, because of those hot flushes and night sweats, my sleep is a little bit disturbed.
Yes, so how about your quality of life?
Yeah, now I'm getting worried about it because previously it was not getting badly affected, but now it is getting affected.
Sorry for bearer for such condition. We'll help you in the best possible way, Phoebe. So, Phoebe, few personal questions, may I?
Yes, sure.
Are you with someone?
Yes, actually, I have my partner with me.
Okay. Any concerns while having sex?
There is a bit dryness down below.
Okay. So are you using any contraception?
Yes, barriers we were using.
Okay, right. So when was your last periods, Phoebe?
Last periods were, yes, they were 3 months before.
Okay, so apart from the general measure, anything else, medications you have tried?
Yes, actually, when I went to my GP, he has told me that he can start some hormones to me, but I didn't agree because I know that my condition is not compatible with that. Just
Okay. Mhm. Any concerns with your periods?
no. Yeah, my
Okay,
periods are off and on coming after 3 months and sometimes 4 months like this.
right. I'll just note it down. Any medical concerns apart from this heart problem which your GP mentioned?
No, this is the only medication that I'm taking.
Okay, can you tell me more detailed about your this?
Yeah, it was a long time ago. It was when I was diagnosed with this condition almost 12 years before. And
Okay,
yeah, but I'm doing well with it.
so that's good. And with your permission, I would like to review your notes.
Yeah, sure.
Right. And any surgeries apart from this in past?
Surgeries, no.
Right. And any allergies?
No.
Okay. Few questions on your social life, may I?
Yes, please.
Do you smoke or take alcohol?
No, I don't smoke. I use alcohol socially only.
Okay. Pardon me for asking recreational drugs.
No.
Okay. Who is support? How is support at home?
Yeah, it's okay, fine.
Okay. I can see you are a bit disturbed. Still wanted to confirm how your mood has been for past few weeks.
Yeah, these are the few things which are bothering me. Otherwise, I'm fine.
Okay. We can connect you with the counselor as well for me.
Mhm.
And what do you do for your living?
Yeah, right now I'm at home. I
Okay.
was teacher before in the
Right.
kindergarten.
Right. I'll just note it down. What's your weight to height ratio?
Yeah, it's 28.
Thank you for the information. Anything else important you want to add on?
Uh, just a minute.
Anything else important you want to add on, Phoebe?
No.
Okay, thank you for the information. Phoebe, I want to examine you in presence of Saffron and may have to examine you down below as well. Is that
Mm-hmm.
okay with you? Yeah, thank you for
Yes.
your cooperation. So now coming to your concern, Phoebe, the symptoms and with your off and on periods, the problems you are facing, we call it as phase. This phase is known as perimenopausal phase, a phase when your periods are about to stop and these symptoms appear and these are little bothering as in your case. Am I
Okay.
clear so far, Phoebe? So because you are heading towards your menses are about to get over and for this symptoms you already have tried general measures, okay, and apart from these general measures we have certain medications which we call it as hormone replacement therapy.
I don't want to do
But
that. I have already told my GP.
yes, I am coming to that, Phoebe. As I can see that you have a heart condition and you're already on a blood thinner. So that medication, we have to connect it to the menopausal clinics and HRT clinics for the same. But as you are already not ready for the hormone therapies, we have certain non-hormonal medications as well.
Mm-hmm.
Okay. And for this, we have certain medications to calm down your nerves, which we call it as anti-anxiety, anti-medications. Okay. And these medications we give so that the symptoms are in a better position. Okay. And also we have some herbal medications as well, but these are not licensed. Am I
Mm-hmm.
clear?
Okay.
Right.
Can I use any
So,
complementary therapy?
sorry, you're not clear, Phoebe.
Can I use any?
Phoebe, your voice is not clear. Can you use what? Hello?
Complementary therapy.
Hello?
Complementary. Complementary therapy.
Okay, for we have certain complementary therapies like cognitive behavior therapy, the talking therapies, they have a good role. Even the relaxation techniques, meditation techniques, they have a good role in stabilizing the symptoms. But yes, the first line therapy, which we say is the hormone replacement therapy, as you are not convinced with it, we have a part. Can I know why you don't want that therapy?
Yeah, because my doctor has told me that is not suitable and safe for me.
Absolutely right. But we have other routes by which we can give, which have a minimal side effects. We have
Mm-hmm.
we have creams. As you have a dryness down below, we have certain lubricants and estrogen creams which you can which will be offered to you. You can try to have a better sexual life. And
Mm-hmm.
coming to your symptoms, these relaxation meditation techniques and the patches, the hormone replacement therapy can be given by the patches.
Mm-hmm.
Okay,
Okay.
so I will be connecting you the counselors. My consultant would be there, would be connecting to the HRT and the menopausal clinics as well. Okay, and your GP would be kept in loop. I will connect you to the support groups as well, like Menopausal Hub. With you can go and discuss to them. But yes, I need to connect you to your heart specialist as well before giving you any medications. That will be given in license with your heart specialist, as you are on blood thinners.
Mm-hmm.
Clear so far? Bobby, I may tell you, I just want to know more why you don't want.
Can I use testosterone?
Uh, Phoebe, testosterone is very upcoming thing, but I may tell you that these have very minimal role in relieving your symptoms, whatever you are having. This is a second line therapy, okay?
I heard it's quite good for the sexual dysfunctions.
Absolutely, yes. They are good for your sexual dysfunction, but yes, the gels which I have prescribed you, they will work in a good manner. And the medications, HRT, which I am telling you with the transdermal patch, they are the first line therapy, and testosterone is usually offered when these HRTs do not work. And I may tell you, testosterone will work just only your sexual functions, but these hormonal therapies will work with your these
Time up,
symptoms of
ma'am.
hot flushes, whatever which for which you are bothered much, along with your sexual, they will improve your sexual functions. Am I clear so far? So I'm giving you the leaflet, go and read it, do think about the options. We are here to help you in the best possible way to relay all your anxieties related to HRT, right? Don't worry, we will not give you anything which is not safe for you and your heart condition. Okay. So do connect to the menopausal hub clinics. And this is the 24/7 number. In case any queries, you can get back to us. I'm fixing an appointment with the consultant. Anything else you want me to address?
No, it's okay.
Okay, thank you for your time.
Thank you. Thank you, Aparna.
I think I messed up.
No, not at all. Can you see my screen now, right?
Yes, ma'am. Ma'am,
Yes,
one thing
ma'am.
I want to ask you, I always fumble in the second half. It is not this station, every station I don't get a channelized way to speak. I speak the way I want and I fumble. So can you just guide me on that?
Yes, 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 sure, Aparna.
Thank you.
Aparna, actually, first of all, see, no one is born confident or no one is born without fumbling, right? This is
Yes,
the
ma'am.
belief that you have to put in your mind
Mm-hmm.
that will make you the most confident person on the earth. This is yourself. You have to
Right.
do it for yourself. This is the acting that you have to
Mhm.
do, that you are the most confident person on the earth, right?
Absolutely
First of
right.
all, make yourself believe that you are the best candidate. If you not believing yourself, you're not believing on yourself, how
Mm.
you can make someone believe on yourself,
Right,
right?
absolutely.
If I am not believing that I am the best, I have already told everyone that I am the born teacher. I am the one who feel extreme pleasure in teaching, right? If I am not the one who is, if I am not confirmed about it, about myself, how I can make you people believe about me, right?
Mm-hmm.
So you will be the one who will 100 times, who will always only one sentence should be circulating in your mind, And that
Mhm.
will be, I am the best candidate. No
Right,
one
ma'am.
sitting here, whether they are examiners, see, examiners are human beings. You have many times, many of you have seen that examiners have placed their handwritten notes in front of them, right? They are human beings. They are not from out of this world. They are also human beings. So everyone has flaws in his or in her own ways, right? But you always believe that I am without any flaws, right? Always say, like I always used to say everyone that yes, every human being is with flaws, but I am not the one, right? So always make yourself believe that you are the best. If you will
Right.
believe in yourself, then you will be able to make other people believe upon you, right?
Okay, ma'am.
All right. So thumbs up, right, Aparna? Now,
Yeah,
never
ma'am.
you will feel that you do not feel about yourself in a bad way. Always feel good about yourself, right? Always appreciate your efforts. See how many people of you have taken out your time to join in this session, right? How many, this is your effort that you are doing. We always appreciate everyone around us. We always make sure that everyone around us is happy and comfortable, but we do not make sure that we are also happy or not. Always make yourself feel good and great every time. Appreciate yourself. Appreciate your efforts, that how hard you are working. Yes, and Aparna, you did very well. You were
She
extremely
did
well.
very well. She
Voice
did
is,
very well. Yeah.
yes, and your voice is so composed. You are
Yeah.
God gifted in this empathetic tone. Like when I was preparing, because I was always like some sort of debater type of student, so I have to work a lot to make voice empathetic, right? You are born with empathetic soft tone voice, right? So along with this, but do not believe on those examiners, sorry, not examiners, do not believe on those mentors who are saying that with empathy you can pass this exam. No, not at all. Along with empathy, complete firm knowledge on the topic, taking
Full
the
package.
station from all around the sides, doing the station in 100% way will make you pass the exam, right? No tone of voice, no like many, you heard it many times that this exam is all about communication. No, not at all. This exam is not all about communication. The most important domain in this exam is to pass the patient safety. If you will pass patient safety in every station, your exam will be passed. If you will pass information gathering in every station, your exam is not going to pass. So while entering the examination hall, your target should be that I will pass patient safety in every station, and mark my words, 100% your exam will pass, right? So Aparna, let's start with the station.
Yes,
Actually,
ma'am.
the station is full of lots of controversies, in a sense that this station comes in different countries in different ways. I will tell you two aspects of this station. First of all, in UK Center, it came like this, right? Mechanical heart valve and taking warfarin. In Egypt Center, the patient was having some mitral heart disease, and she was taking labetalol or atenolol, some sort of she was having hypertension, and she was taking some antihypertensive. He was
Ma'am,
not having,
propranolol. She was taking propranolol.
yes, something like this. And she
Yeah.
was not taking warfarin. She was not having mechanical heart valve, right? So this station came in two different ways. Now actually how we have to decide, you know that when I'm speaking with you about this station, I have worked for this station. Can you believe, for this only one station I have spent maybe probably more than 1 week on this station. This station was in my head all the time. You cannot imagine that how much time I have spent in preparing the station, in collecting information, in collecting passing points of the station, in collecting all the points which are mentioned in the scorecard about the station, right? Because when I am with you guys, this is my responsibility to give all the correct information from the scorecard. Otherwise, there is no fun of doing station with you. Otherwise, you two friends can also do the station with each other, right? So listen to me. First of all, what information I have collected after so much hard work is this. No problem, Sania, Rekha. Thank you so much. Okay, all right. So what I have gathered is this: in which form the station will come. You should be knowing the basic important information. Now, Aparna, I have noticed your points is this. See your agenda making, introduction, Yeah, Fatima, I am doing those stations who nobody is daring to touch these stations, but I touch these stations, but I touched after full preparation, right? After gathering all the important points from the scorecard, all the patient safety points, then I plan to touch these stations. See, your introduction agenda was perfect, no doubt in that. Then coming to the information gathering, your information gathering was absolutely fine about all my symptoms you have inquired, about all the postmenopausal symptom, my last menstrual period, my all information you have gathered. See the complete information gathering, these probably 10 to 20 questions, these will make you pass in the information gathering. You have to pass every domain, but basic target will be patient safety. Can you tell me more about your concerns? Are you experiencing hot flushes and night sweats, mood swings, low mood? Now when I have asked you that my sexual quality, like I am not having any interest in the sex, you were giving me vaginal estrogens. Vaginal estrogens are not correcting her sexual dysfunctions. Vaginal estrogen will only lubricate, will only reduce the vaginal dryness. Aparna, are you with me? When I have asked you that I want to improve my sexual dysfunction, you told me that testosterone are not required because I have already given you vaginal estrogens.
Ma'am, is it sexual dysfunction you're talking about, or whether
I will
it
tell
is
you.
loss of
These
libido?
are two symptoms. See, sexual dysfunction or loss of interest, whatever line the patient is using, whatever word the patient is using, but these are two separate things. Vaginal dryness is a separate thing. Loss of interest is a separate thing, and both treatments are separate thing. Vaginal dryness means you can give vaginal estrogens or moisturizers, repellents, Replin or vaginal moisturizer. These are, even in the group, I will share some screenshots from strategy that I have gathered, right? I will share the screenshots in the AlphaMed group, right? And the RedX classification as well, right? So listen to me carefully. After taking all these symptoms, the loss of interest, its treatment is not vaginal moisturizers. Its treatment is different. We will touch all the topics and their treatment one by one. Then you have not inquired me. Hello, Sahitya. Thank you so much, Sahitya, for joining. I was waiting for you. Okay, all right. So let's move forward. So contraception, you have not asked that have you ever used COCs or not? This is the question which is asked by the passing candidates, right? Because if patient is having mechanical heart valve, whether she has ever used COCs or not, right? When was your last visit with a heart specialist? What medication you are using, any recent lab test done in the last 12 weeks, because patients who are using warfarin, they have to do their INR test after every 12 weeks, right? Any concern, palpitation, edema, irregular heartbeat, any history of clot formation in the past. These all are the points. We will take the station in two directions. One is mechanical heart valve and warfarin, and other is a patient who is having mitral stenosis or mitral valve prolapse or something like this and was taking atenolol or propranolol, whatever she was taking, right? So in these two, all these questions are must to ask in these patients, right? Muscle joint pain, periods, LMP, intermenstrual bleed, postcoital bleed, cervical smear, are you sexually active, vaginal dryness, and always before starting any of these questions, always make your signposting very, very short. Do not do a long line signposting. Only say, can I ask some personal questions, please? That is it, right? Do not make your longer stories. When was the last visit to heart specialist, INR, if you want to ask? Okay, now listen. This is the explanation of
Ma'am,
perimenopause.
ma'am, I have a query in previous slide.
Yes, in
Like,
this.
uh, cervical smear and family history of clots, I forgot somehow. For this thing, I just asked an open-ended question about contraception, and for heart thing, I said that I will review your notes. Any concerns? So I just asked an open-ended question.
Yeah, that
Obs
also,
history,
yeah, it's covers. These are covered, my dear Aparna. Yes, absolutely.
obs history, I purposely missed. Reason being, I thought to take a focus history, and obs in HRT has no relevance. So that's why I missed it purposely. So is it okay or? Smear, so I agree. That was my mistake. Family history of clots. That didn't come in my mind.
Varna, actually, the thing is this, if we will become so selective at this point, see, if we are try to remember 80% of things, in the
Mhm.
exam, you will be able to recall 60%,
Right,
right?
ma'am.
So it is important that at this point, even I've slide ended over there. Otherwise, I want to take it to the end of the story, right?
Okay.
Always take structured history doesn't mean to leave the basic history point. Structured history mean do not include any irrelevant point over here, right?
Okay.
So these are not included in your structured history. These are the basic history from the patient. You asked me medical, surgical, social. You have taken all the points.
Yeah. So obs
Ma'am,
history
pregnant.
should also be included.
Yes, you can ask. How many kids do
Okay.
you have? That is
Right.
enough.
Another thing, ma'am, like I
I'm
asked
pregnant.
contraception, should we specifically focus on COC? And for heart condition, whatever questions you mentioned, should we specifically ask or any
These,
open?
yes, these are the questions. Have you ever used COCs? These
Okay.
are the questions who have been asked by the student who have scored more than 75% marks in the last exam. Have you
Right.
ever used COCs? Particularly, he asked about this question from the patient, right? To know that because of this heart condition, but she was not the patient who was using mechanical heart valve. She was the patient who was having mitral valve problem and was using some beta block, right? Now listen, Aparna, when you have started giving me options, what you should do. See, when there will be a new station and you have to take a long history to reach the exact problem and to reach the exact concern of the patient, when you will see your time have almost like 6 minutes or 5 minutes must have gone. So what is the strategy at that time? Immediately you should have asked the patient, is there any specific preference from your side? Right? This is what this candidate has done. She was not she he was actually asked from the he actually asked from the role player that what is your preference exactly. See, we will go ahead with the management plan. First of all, explanation. Aparna, you did excellent explanation. You have told me what is exactly the perimenopause means. This can last from few months to several years. Menopause can occur earlier in some women. If it occurs before the age of 40, it is known as premature menopause, as you are 45. So we are not going to do any hormone test. Period before having the menopause is called perimenopausal state, right? You were absolutely time before your last period when your estrogen levels are falling are called perimenopause, right? So explanation was perfect about it. Now the management plan, your first question should be, do you have any preference? Immediately the role player replied, I do not want HRT. Is there any other option for me? Right? Now, what other options? Because we cannot say to the patient that nothing is suitable for you. The simple patient who is having mitral valve stenosis or mitral valve prolapse and taking propranolol, or many options are suitable for that patient, right? But the patient who is having warfarin, she is not suitable for many things. I have never gone for my exam to the British National Formulary, but even for you people, I have even explored that as well, right? Ravni, thank you so much for joining. Okay, so what I have concluded is that, and what about the exact scorecard is? Scorecard is about when the patient will say that I do not want HRT, is there any other option for me? Then lifestyle changes. Aparna, in the lifestyle changes, for the menopausal patient or any perimenopausal symptoms, always take names of these exercises because these are the exercises which will help to release some brain chemicals which are happy chemicals in terms of which will help in her mood and he'll help in her like in many ways it is going to help her, right, to maintain optimum BMI and to maintain many things because lifestyle changes for every condition are different. For urogyne, SUI, lifestyle modifications are different. For overactive bladder, lifestyle modifications are different. For bladder pain syndrome, they are different. For menopause, lifestyle modifications are different. These are regular aerobic exercises, right? Along with that, low intensity exercise such as yoga, reducing your intake of caffeine, alcohol, swimming, running. These are the low intensity exercises which are going to help her. So always take the name of these exercises so that be very specific which sort of lifestyle changes you want from her.
Not only that you should make healthy lifestyle changes. What do you mean by healthy lifestyle changes? Never say like this. Aparna, it's not about you. You have not told like this. I'm just giving the idea, generalized idea of this station, right? I'm not talking about your discussion.
No, ma'am.
Okay. Then reduce caffeine, reduce alcohol. So be very specific. Even try to memorize the names of each exercise which you have to tell about each lifestyle change. Reduce caffeine, reduce alcohol. Then you have to tell that you have certain options. These are pharmacological options and non-pharmacological options. In the pharmacological options, you have hormonal options and non-hormonal options. Hormonal option, HRT, this is the hormonal treatment. She has already told that I do not want to take it. It is not safe to take patients who are taking long-term anticoagulants. Now, I want to, ma'am, pregnancy test should be done first. Yes, Deepika, pregnancy test should be done first. You are right. See, now, what strategy is telling about the HRT is this, and the patient who is taking long-term anticoagulant. According to strategy, HRT is totally contraindicated for the patients who are using long-term menopausal symptoms that I said. Okay. HRT strategy says that in the long-term anticoagulant, HRT is contraindicated, right? It is clearly mentioned in the strategy. It is clearly mentioned in the TOG article that any patient who is having long-term heart disease, HRT is contraindicated. What we can do is that, what my idea about HRT and the patch thing is this. See, if the patient is having, what my suggestion is this, if the patient is having simple heart disease, simple means not mechanical heart valve and not taking warfarin, you can say that after connection with the menopausal specialist, we can, if she's agreeing with the HRT, right? This patient is a totally different because they are into some other agenda. I will tell you what was the agenda and what was the trap that the RCOG has spread for the candidates. I will come to that trap as well. HRT is this, that after consultation with a menopausal specialist, the patch for the hormonal replacement therapy are available, which has a very low risk of the clot formation, even to the normal regular patients, right? Because they are not absorbed and they are not having the effect like the oral HRT is having. Because the patch HRT is equal to nothing, right? But in case of warfarin, in case of patient who is taking warfarin, do not prescribe anything in terms of like oral HRT, or she has not even given the opportunity to prescribe patch even. But if each patient will be insisting, you can discuss the patch. There is no point that you should not discuss the patch, but you should say that after discussion with a menopausal specialist, then we can discuss that option with you, right? Along with the hormonal, then there is a non-hormonal medication, clonidine and SSRI. Now see, a big trap that has been put for the candidate is basically that the complementary therapy is totally not recommended with warfarin. This is the reason that they have put this question for the patient, can I take complementary therapy? Complementary therapy include black cohosh and the St. John worts. These both are evidence-based effect on the menopausal symptoms. These are not by any quacks or by anything. These are evidence-based complementary therapy for correction of the menopausal symptoms. But they have interaction with the warfarin. This is the reason you will say there is not enough information to say that herbal remedies and supplements are safe to take with warfarin. Right? It is a complementary therapy. There is some evidence that it may benefit for the hot flushes, night sweat. These are evidence-based. This is not like not evidence-based, but uncertainty about its appropriate dose, variation in nature, potency of preparation. What is concerned is potential serious interaction with the warfarin, right? Do not prescribe the patient St. John wort, black cohosh, or any herbal medicine. Herbal medicine, which are the plant extracts, black cohosh, isoflavone, soya, all these can have interaction with warfarin. So all these complementary therapy are not safe for you. Acupuncture, hypnotherapy, reflexology, data have shown no significant effect, right? These have no significant effect on your symptom, right? See, we are here to give correct information to the patient. We are not allowed to give any wrong information to the patient. I will tell to the SSRI and clonidine as well, Anam. I have purposely skipped that slide because I want to first of all kill this point. This was
Ma'am,
the
what about with metoprolol?
I will just tell everything. Just a minute. Just a minute. Let me go stepwise. Otherwise, I have made a lot of slides for you so that every medicine point will be clear. This was the trap for the students who were appearing from the UK center, so that with the warfarin, they will say that if patient is not willing for HRT, definitely we have to give something to the patient. How we can send the patient back without giving anything? This is the trap that was laid for them. That sends on what? Herbal remedies, all these are totally have interaction with the warfarin, so these are not safe to take with warfarin, right? These all are the complementary therapy. Acupressure, hypnotherapy, reflexology, no significant effect will be, right? Now coming to other big things. Yes, see clonidine. If you will search clonidine with warfarin on NHS site, and even in BNF, warfarin and clonidine have no interaction. But actually, the story is different. What is the difference in that? Clonidine actually is causing derangement in INR sometime. It can cause prolonged bleeding sometime. Similarly, I asked you testosterone. I will come to these, I will clear these every point of this station. When the patient will say that I want to take testosterone, what will be your answer, right? Taking testosterone with the medicine that you are taking can lead you to bleed easily. Your doctor may need to monitor you closely because see, testosterone and clonidine, these can be given, but along with that, your heart specialist will monitor your INR or your test so that your bleeding capacity will not be increased, so that you will not bleed easily, right? You will not bleed easily, and how your blood thinning medicines are working. To see these two effects, your heart specialist and the menopausal specialist will discuss with you these options. But these are not contraindicated at all, right? These are not going to do interaction, but these are going to affect the ability of the warfarin, and it can lead to prolonging of the INR. This is the reason that warfarin dose need to be adjusted with these two medicines. But SSRI, not the first line, there is some interaction with warfarin and antidepressant. Never at all you are giving SSRI to the patient. Never at all you are giving herbal or complementary medicine to the patient. These two medicines you are not going to give to this patient who is taking warfarin. But what you are going to do is this: clonidine and testosterone. Yes, Deepika, has effects on heart. This is the reason that this will be given only after consultation with heart specialist and only interaction with her menopausal specialist, right? Because testosterone is also a form of HRT. Clonidine is a different thing, right? Testosterone has severe effect on the heart. But the total absolute contraindication are basically these things: HRT and along with complementary therapy, right? So these are the medicine which have a lots of gray areas, how you are going to cover and how you will consult the patient in this. Now listen to me carefully. What was the name of the patient? Whatever the name of the patient, Phoebe was the name probably. Phoebe, first of all, we are going to advise you certain lifestyle changes. We suggest that you do regular aerobic exercises, such as running, swimming, and this low intensity exercises, such as yoga as well. Reducing your intake of caffeine and alcohol will help you to reduce hot flashes and the night sweats. We have certain options of hormonal and non-hormonal medication, and pharmacological and non-pharmacological medication. Just a minute, someone on the chat box. Deepika, my dear, tibolone is actually comes at the very end of the list, right? So we are not going to talk about tibolone. If you are talking about sexual problem or the dysfunction, this problem, loss of interest in the sex, the first line treatment is HRT, right? Second line treatment is basically testosterone, if HRT is not going to affect. So tibolone is nowhere according to the NICE guideline. Do not put yourself in a situation which is not recommended anywhere, right?
Dr. Asma, can I just ask you one question?
No, you can ask
So
me 100
loss of
questions.
sorry?
You can ask me 100 questions.
No, thank you. Loss of interest in sex, this will be going for psychosexual counseling, whereas
You can say libido, you can say less libido. Because we are
yeah,
not going to
exactly.
in
Yeah,
more
because they
detail.
have
We are
got
not going to
little
discuss
difference in
vaginismus
yeah,
here.
yeah.
right?
Yeah.
And you
Right.
can see
Yeah.
its libido, right?
Yeah.
These are synonyms of each other, right? I am here for the session so that you can ask maximum questions, right?
Thank you so much.
So,
Thank
yes. So what I was talking, pharmacological and non-pharmacological. In pharmacological, we have hormonal and non-hormonal. So after hormonal, you will discuss, then she will say that I do not want to take hormonal. Then we have an option of your heart for hot flashes and night sweats. Clonidine is not the first line treatment. It can reduce your hot flashes and night sweats. It is associated with certain side effects. It is basically used to treat raised blood pressure. Side effects are basically dizziness and sleep disturbance and low blood pressure. I have taken these 3 side effects straight from the strategy, right? Every word is taken and chosen very carefully. This is the reason these are not line made by me. These are taken from extremely authentic resources, right? SSRI are also, and these are for her hot flashes and night sweats. For her anxiety, or if she's having low mood, then CBT you are going to give. SSRI is not first line and they have interaction with warfarin. These are not safe for you. These are not suggested for you. Although literature says that sertraline and citalopram are safe, but no need to mention this. You can straightforwardly say that these have some interaction with warfarin. Be very straightforward with the patient, because if you are not going to avoid these medications, your patient safety will total go fail. What they want to see you, that you are not going to prescribe St. John wort to the patient. If anyone will say that yes, these are the complementary therapy and you can give this is you need to yes, exactly. If you will say that you can use this complementary therapy, this can helpful for you, patient safety will total go fail. How much empathetic you are, how much good tone and information gathering you have taken, your station can never go past. This was the trap laid basically for the
you.
students, right?
Dr. Asma, there was one more complementary therapy na, in this, some cactus, something.
Cactus.
3 words, something is there in this.
Cactus, I don't know, but maybe
No, that is
Uh,
Agnes cactus. That is not for this. That
Agnes,
is for PMS.
is it
That
for
one.
PMS?
Yeah,
Yeah.
PMS and
Okay, okay.
dysmenorrhea. For this, it is not there. For this, it is
Right.
Jingo biloba, St. John's wort, and all
Yeah,
those
Jingo
stuff.
Yeah.
biloba. I think that also has come in the station once.
Black cohosh.
Can I use Jingo biloba, something like that?
nothing. Just tell them nothing. Go back home and stay comfortable. Nothing is allowed, right? When the complementary therapy, they have told that all these complementary herbal medication, which are made from plant, all these are the plant extracts. They have interaction with the warfarin, right? So nothing is allowed, right? This is the patient safety point. Patient safety point is referring the patient to the specialist menopausal clinic. If you will see, we always think that this point in which the communication with colleague, MDT, we always think that the point of MDT comes in this domain only. But there are certain scorecards where communication with colleague or MDT will be in the passing point, right? In this station, referring the patient to the specialist menopausal clinic is a 100% patient safety point. Giving the safe alternate options to relieve her symptoms, lifestyle modification, clonidine after consultation, specialist dose adjustment with INR, explaining her condition with risk of each options, no complementary therapy. Only these points, and whatever things you have done in the station, your station is pass, right? These are basically exact points to pass the station. The patient agrees, get it prescribed. Arnav, my dear, what my suggestion is this: transdermal patch can be prescribed for those patients who are using antihypertensive, right? But I will suggest that if patient is agreeing for HRT, you can say that we have an option of hormone replacement therapy in the form of patch, which has got very low risk of clot formation, right? But that will be suggested to you after consultation with a menopausal specialist, because to somehow the patients who are having Arnav, in this patient, HRT even in the form of patch is not very like appreciable, because this patient is taking warfarin, and long-term anticoagulation are straightforward contraindication. But you can mention the name of HRT in the form of patch, and also tell that these are having extremely low risk of clot formation, and we will discuss with the
menopausal specialist. But in the form of, if patient is having simple heart disease and patient is taking some antihypertensive, then you can definitely recommend patch. And all the students who passed from Egypt Center, they have recommended HRT in the form of patch, right? Patch form they have given, every student have given who have passed the exam, they have given the patch form of HRT. Because in the form of patch, side effects are extremely like nil, right? So patch is the safest option. But in this station, patch was not the trap. Trap was actually the complementary therapy, right? This is the reason that she was asking it again. And this is the reason that she herself declined the patch. She has herself declined HRT. All right. So how is the station?
It means, doctor, if the patient is taking anticoagulants, we can give HRT patches.
Not exactly, not ourselves.
A menopausal clinic, basically.
Yes.
Ma'am, complementary with metoprolol, because that was the question.
Yes, that can be given.
Ma'am, the other variation you said with propranolol and
Yes,
mitrivol.
we can give complementary, my dear. That has only interaction with warfarin.
Ma'am, in that case, can we give HRT only in patches or can we give oral as such?
No, patches only. Only patches.
Okay.
She was hypertensive. Her blood pressure was raised in the Egypt Center, right?
Okay.
Ma'am, excuse me, ma'am. So ultimately, in this patient, the only safe thing would be clonidine, and that too after having consultation at a specialist menopause clinic.
Vaginal estrogens,
No else
right?
pharmacology.
Vaginal moisturizers, vaginal estrogens, clonidine, lifestyle modifications, right? These are safer options for her.
Ma'am,
Okay,
so
ma'am.
with hypertension, it is transdermal HRT and
Exactly.
SSRI also, no? SSRI is complementary
yes.
therapy, everything we can give it.
Yeah, exactly.
Ma'am, in the other case,
See, my slide is
can
changing.
in the other case with mitrivol, prolapse and propranolol, can we change propranolol to this clonidine? It can take care of hypertension as such.
We ourselves are not going to change any hypertensive medication.
We can refer the patient.
Right? Patient is already using
So,
something. See, my slide is changing.
ma'am, clonidine can be given in the second case?
In which case? In warfarin?
Yeah, with propranolol, mitrivol, stenopur.
Yes, but in that you are giving HRT patch form.
The clonidine comes second line.
Why to give clonidine when she's suitable for the patch?
Okay.
See, my slide is changing.
No, ma'am.
No, ma'am.
So,
No, ma'am.
Okay, can I start the next station?
Can I do this time, please?
Yeah. Anyone can do, please.
Thank
This is the station. Just a minute. Few of my students are knowing about this station, so please, they should stay quiet. Because I do know this is also exactly a new recall, right? So this is because some of friends have requested for this station. This is the reason I have included this. Just a minute.
So, Dr. Asma, I have not prepared anything, so.
Nothing, no problem at all. I have not prepared. No, don't worry at all. We two are same. It's not weird. I'm not taking your exam, right?
No, I'm just telling, like,
This
yeah,
is
I'm
just
not yet.
some friends are sitting together and we are discussing few things. So don't worry.
Yeah, that's fine.
Just a minute. Okay, so who is going to start the timer? If I will start timer, just a minute, I cannot.
Ma'am, slide is not changing.
I am not changing it, my dear, because I'm starting the new station. Okay, so timer, I'm going to start. Okay, so start, please. Who is going to start the station? Your name, please?
I'm good. Maya.
Okay, Maya, let's start.
Do we have any other slide?
No.
Okay.
Okay, start.
Hi, I'm Dr. Jaiswal. I'm the ST5 working in the clinic today. Can I please confirm your name and age?
Yes, doctor. I'm Ruby Stoke. I'm 26 years.
Yes, and how can I call you?
Yes, Ruby is okay.
Yes, Ruby. Ruby, I understand that you are in your 23 weeks of your pregnancy, and you have started with some pain. Is this right?
Yes, doctor. I'm quite worried about it. It's just too early.
Yeah, I mean, I can see that you're really concerned about it, and we'll discuss further about the further plan and management, Ruby. Am I okay to ask you a couple of questions?
Yes, yes, sure.
Can you tell me, Ruby, what exactly happened and how it started?
Actually, doctor, everything was going fine. Me and my partner are very happy for this pregnancy. And since last night, I was having just mild pain in my lower tummy, but now its regular contractions have started. And nurse have examined me, and she's saying that I'm just labor is about to progress, and I'm quite worried about it. Baby's too. It's very early in the pregnancy.
Yeah, I mean, I can see that you are just 23 weeks at the moment, and baby is really very small. This should not have happened, but yes, I mean, I can see that the nurse has examined you already, and yes, you are already in labor. I'm so sorry to inform you that, Ruby, that yes, that is right. Um, am I okay to ask you some few questions so that I can understand that why this has happened?
Yes, sure.
Is this your first pregnancy, Ruby?
Yes, it is.
Okay. And can you tell me a little bit more about this pregnancy? How was the pregnancy doing so far up till now?
Pregnancy was going fine, no problem at all.
Mm-hmm. And how was the ultrasound and blood checks and everything was okay?
Yes, everything was okay.
All right. Have you had any problems so far in this pregnancy? Any blood pressures, any diabetes, anything?
No.
Okay. And have you got any operations or anything in past?
Operations, no.
Okay. Any miscarriage in past?
No.
Okay.
Yeah.
Have you got any? Have you got any? Sorry, I think some mics are mute.
Yeah, there's
Can you mute the mic, please? Okay. Have you got any past history of any smoking?
No.
Okay. And any alcohol?
No.
Okay. Have you done your pap smear?
Smears were fine.
Okay. And have you got any past history of any sexually transmitted disease or anything, Ruby?
No.
Okay. That's fine, Ruby. Also, how is your support at home?
Support is okay.
That's good. And do you
Oh
have
my God.
social?
Oh.
Are you okay?
I'm having pains, doctor.
Oh, I'm so sorry. Ruby, let me just quickly check you. And I think we need to go further. So, am I okay to admit you now, since you are already in pains? And I'm going to quickly give you some medications. Is that okay for the pain?
Yes, sure. Thank
Okay.
you.
Thank you, Ruby. Ruby, also, I would like to tell you, because this is a premature labor now. This is a condition in which there is the labor pains have already started much before. We are worried about the maturity of the baby. So I'm going to do immediate connection with the neonatologist team which we have, and also our consultant will come and will have a talk with you.
So can you
But
do
in
something to
this,
stop these pains, please?
yeah, so we are just going to give you immediately some painkillers. Is that okay?
No, can you stop the labor, please?
So Ruby, currently you are 23 weeks at the moment, and you are already 5 centimeter dilated, and you know you are already open quite significantly. Your membranes are good, but at this point, it is difficult to stop the labor pains. You are already in advanced labor, and you are having good amount of pains. So it is really difficult to stop this pain, Ruby. Unfortunately, the baby may come out small. Okay, so what we are going to do is to give some support to the baby. There is something called a steroid injection, which we normally give you so that we can have some lung maturity of the baby. So we can offer you that, but there are some side effects which are associated with the steroid injections. We need to weigh the risk and balance both of us together, and then you can decide whether you wish to take the steroid injections or not. Okay.
All right. So what do you think that if baby will be born at 23 weeks, the baby will be fine?
It's a very, very difficult question to answer, Ruby. So my neonatologist team, they will be able to, baby may need the ICU, what we have a critical care unit in which we can keep the baby. The baby is going to be very, very small. I don't want to give you a very high hopes at this moment, but the baby is going to be very small. Most of the time it is seen that the once baby is more than 24 weeks, the chances of survival and everything is little better. But when the baby is less than 24 weeks, we do have a chance, but it is very difficult to comment. It all depends on how the baby is going to respond to that. Okay. The prematurity, sometimes it's a very small baby. So there can be sometimes the risk can happen or damage can happen to the brain. To prevent the brain, there are certain times the baby may have some, something, trauma to the brain, which can happen because of at the time of labor. Okay, so it's a small baby, so we need to really see how the baby is going to be. Okay, so we are just going to take you in labor ward. We are going to monitor you completely, but at this particular time, it is going to be difficult to do anything right now. There are certain cases in which we can do the cervical stitch, but it is not for your case because you have a regular pains which is already coming up and you are already more than 5 centimeter. So that is going to be causing the more trauma. There can be the risk of bleeding. There can be the risk that, the pains will not stop. Are you with me?
Right.
So, Ruby, I can definitely tell you that with your next time, we can definitely investigate and find it out that what could be the reason. There can be sometimes, the cervix, the womb neck, which we call, it is a little bit weaker for some people. So that is something which we call as cervical incompetence. Sometimes if someone is having...
Time up. Okay, keep on, continue the station, but your time up.
Okay, so sometimes if the cervical is the tissues of the cervix is little weak, then such kind of thing can happen. So we can definitely refer you to the next time, the preterm clinic and the other clinic, Rainbow Clinic, where we can do some more investigations later on for you.
Okay, all right, doctor.
I don't know, I did very bad.
No, it was good. May I know your name, please? Sorry, I forgot about the name.
Maya.
Maya, my dear, it was not bad. Don't think about you like this. I have already told you that always think best for yourself. Always think
Yeah, but
you are
I'm
best in
reading the
different
station for the
ways.
first time.
No, it's a very, very good. Yeah, Rajani, thank you so much for
Thank you.
appreciating Maya. Maya, it's not like this. See how calm, how comfortable voice you have.
Thank you.
See, it's no, it was wonderful, and you touched many important points in a very good way, right? You started the station very well. Your information gathering was good, except to ask about STI to the pregnant patient and the smear, right?
Hmm.
So it was not required, but you have formulated the agenda very well. And coming to the, because you were
I
seeing,
was thinking actually, Dr. Asma, the reason why she started with pain, because I was expecting actually that this lady must be smoker. But that I
I
found that
see.
that was a negative history. Even she never had any pap smears or anything. So HPV was also ruled out. There was no cervical, what you call, any stitch or anything, like any cautery or anything. There was no history. So I was wondering that what it could be. Then maybe there is a sometimes past history of STI or something which
Recent
could have.
recall. Dr. Maya, my dear, this is a recent recall station in which patient is in the preterm labor. And
Mhm.
this is this after this, I have already Fatima, are you here in the in the session? She is not here. She has told me about one point and I have prepared that. Okay, all
Mhm.
right. Probably hear the recording. Okay, so Dr. Maya, actually in this station, this is a recent recall from the November exam, right? She is
Mhm.
a patient who I will take the station forward and I will let you know that how we have to cover the patient safety points and the passing points of the station, right?
Mhm.
See, just start with me. First of all, after telling the patient introduction, agenda, everything, first of all, this patient was in pain. At the very first, you should have offered me pain relief, right?
Mm.
At the very first, you should have asked me that whether the pain relief has been given to me by nurse or not. And then you
Mm.
should have started the history taking. How are you
Mm.
coping with the pains? Have your water broken or not? Any bleeding? How are the fetal baby movements? Any discharge? Any fever? Urinary complaint? Any surgery on the neck of the womb? And ruling out the history of domestic violence in the patient who is having prematurity, right?
Yes.
In the prematurity, always rule out domestic violence. Although the labor patient's history is always less, any history of STI I have already written. STI probably because of any sort of infection, right? Otherwise, it is not very required. Allergies,
Mm.
all investigations are fine. Any concern or not? Any infection in the past? Basically, it should
Mm.
be infection, not exactly STI, right? Any
Mm.
discharge, any infection in the past. Then explanation of situation.
Mm.
Actually, you have not explained me what exactly from the situation I am passing through. You told me that I have gone in labor before time, right? But
Mm.
it should be in
Mm.
a very clear way so that patient will be knowing that what's wrong is going to happen with her and what are its consequences. You should have told
Mm.
me that when the process
I
of labor
told
begins,
preterm labor. Mm.
no, not only preterm labor. Listen to me. When the
Mm.
process of labor, it starts at 37 weeks, we call it as a term labor. But you are
Mm.
having regular contraction along with the
Mm.
progressive opening of the neck of the womb. It is 5 centimeter already dilated. We call this condition as established preterm labor. First of all,
Mm.
she is at 23 weeks, so she is at preterm labor. Secondly, she is 5 centimeter dilated, so she is in established preterm labor,
We
right?
can call advanced preterm labor
No,
also.
no. The terms which are used in the guidelines are important to use in exam to tell
Okay.
the examiner that you are knowing about the significance of this term. And
Right.
second,
Yeah.
telling the patient correct diagnosis, telling the patient exact situation that she is passing through is the most important thing. This situation is associated with few risks to you and your baby. Your baby can having breathing difficulties, infection, brain damage, and cord prolapse. These are the
Mm.
risks that baby is having. These are the only 4 risks that you need to mention. Otherwise, for
Mm.
prematurity, you can mention a lot of because rescue circulate till what dilation can be done. Rescue circulage, Arnav, or just a minute, Arnav, I will mention that. MDT, Arnav, rescue circulage has nothing to do with this station because she's in established preterm labor. There are 3 types of preterm labor. suspected preterm labors, diagnosed preterm labors, and established preterm labors. Suspected preterm labor is a patient who is only having symptoms. Diagnosed preterm labor, in which via the TVS or certain fetal fibronectin tests are done, that is a diagnosed preterm labor. Established preterm labor, that is more than 4 centimeter according to NICE guideline, and more than 5 centimeter according to labor care guide. Right? So she's 5 centimeter dilated, established preterm labor, tell her exactly what is her diagnosis. And then it's associated risk on the mother and the baby. MDT involvement, you have told me, then management plan will start with sending certain tests, HVS, midstream urine, ultrasound to see fetal weight and gender, because these are the 2 factors which are going to affect all the management plan of the patient. Now, what was the name of the patient, Maya?
I forgot.
Ruby.
Yeah.
Ruby, actually, we can take your case in, we have 3 choices at this time. Do not say options. We have 3 choices to proceed with your management. First choice is that we can do the active management of you and recourse to cesarean section if CTG reveal any problem in the baby's heart rate. The other, what I was telling, not option.
But we don't do CTG in less than 24 weeks, no, Dr.
Listen. Let me complete first. The TOG article of extreme prematurity has given these 3 options to the baby. Right? Second option is this. Second chance that we can give, and second way in which we can take the pregnancy forward is this. Consider passive management, involve no cesarean section. Passive management means we will continue to monitor the baby, but even if any problem in the heart rate arise, we are not going to do the cesarean section. But when baby will be born, resuscitation will be attempted. Third option is this, or the third way of taking forward the pregnancy is this: palliative management, provided the comfort care if live birth starts, if live birth ensues. Right? These are the 3 ways to take this pregnancy forward. These are the 3 things that you have to tell the patient. First is doing an active management. It means we will monitor the baby actively. If you do not want to mention the name of CTG was mentioned by the TOG article, right? If you do not want to mention it, it's okay. You can say that we can monitor the baby. If there is any concern, we can do the cesarean section. And after the delivery, we will do full resuscitation of the baby. Second choice is that we will do the passive management. If there is any concern involved, we will not do the cesarean section. But when the baby will be born, resuscitation will be done. Third choice is that if the live birth ensues, then we will do the palliative management of the baby, right? At this age, with perfect care provided, with ideal facilities, giving the best possible care in the best possible place. Please note down these points. Giving the best possible care in the best possible place. We have 4 out of 10 babies will survive, and 1 out of 4 have severe disability in walking, learning, difficulty in hearing, and the brain damage, right? This is the outcome of the baby in this scenario. So what do you think, that tocolysis is important, should be given for the patient or not? What is the decision of the house? What other students are suggesting for this? What are the suggestions? Whether the tocolysis is recommended or not?
Ma'am, if she is level 2 NICU facility, then for the transfer and with the steroid cover only.
No tocolysis in established labor. We will say no tocolysis in established labor. It will not work. Rather, it will make your womb relax and increase the risk of bleeding after the delivery, right? And the other thing is that steroid will be given, because steroids are recommended even for the established labor as well, right? Agree?
Yeah.
But ma'am, for steroid cover, tocolysis, the only indication for tocolysis now is transfer and the steroid cover.
Yes, that is the only indication for tocolysis. But here tocolysis indication is not justified because patient is having regular contraction. She's in established labor, right?
Yeah.
Established preterm labor,
no
circulage.
We have to tell that prognosis is very bad at this stage, and even by cesarean section, outcome of the...
You will not say prognosis is very bad. You will say these words, what I have told you. Given the best possible baby care in the best possible place, 4 out of 10 babies will survive, and 1 out of 4 baby have severe disability in walking problem, learning difficulty, and brain damage. And these are the 3 choices to take this pregnancy forward, right? but do not put her in a situation in which it's not an examination for her, right? Do not make a situation difficult for her. And like other stations, do not ask from her that what option you are choosing now, right? Just tell that we can take this pregnancy in this manner. Only this. She's already in agony. She's already passing through difficult time. Do not make her situation more difficult, right? So do not put her situation difficult. Just tell her that sometime we do this, sometime we can do this, sometime we can also do this, right? And this is the outcome of the baby as well. And then after this, you can tell that after delivery, placenta will be examined with a microscope. And in the next, the delayed cord clamping, when the baby will be born, delayed cord clamping will be done. Level 3 care bed will be provided. NICU facilities will be checked. Placental histology will be checked as well. After birth, yes, antibiotics will be given or not? What is the decision of the house?
Yes, given.
No, regular
Yes,
antibiotics
given
depending upon.
antibiotics will be given.
Yes.
Antibiotics will be given to the patient, right? Antibiotics will be given to the patient and steroids will be given to the patient.
Preterm labor. Yeah.
Right?
GBS prophylaxis.
GBS prophylaxis as well?
GBS prophylaxis, yeah. Yeah. GBS
What
prophylaxis
about
will come.
MEC-self? What is the consensus for
No,
the MEC-self?
24 weeks onwards. 24 weeks onwards.
24.
Yes,
To
this is
29
not
plus
PPROM.
6.
This is not PPROM. Membranes are intact. What about MEC-self?
No
Ma'am,
MEC
we
self.
can 24 to 29 plus 6 weeks.
Yeah.
Yes.
But it can be considered in very preterm also.
Yes,
Can be considered. Can be considered.
Yes, can be considered. For women between 23 to 23 plus 6 weeks who are in established preterm labor or have planned birth within 24 hours, discuss with women use of MEC-self for neuroprotection in context of individual circumstances. So you will say that this can be discussed, right? It can be considered. It is not like this that we will see total no. Got my point, please?
You know, Dr.
Ma'am,
Asma,
I
the way you
could
have
not
explained
understand
this
the
slide.
first option. The first, active management with recourse to
Active
cesarean
management
section. How we
means,
will...
yeah, listen to me. Active management means patient is 5 centimeter dilated. We will monitor the baby, whether by the fetal hearts or by anything. If any concern arise, we will decide that we will do the cesarean section. And we will do...
But ma'am, before
like we do
24
regular,
weeks...
yeah, like we
Yeah.
will do for the regular baby. She has the right. She is a patient who is losing her baby, right? She has the right that her baby can be considered as a normal baby. So these are the options which are given by these are not made by me. These are not made by any other mentor. These are made by the TOG articles, right? Ravneet, my dear, steroids
Dr.
can
Asma?
be considered. Steroids can be given before 24 weeks. These are discussed with women in context of individual circumstances and preferences, right? Steroid and MEC-self, same story you will say. Steroids can be given in the established.
Ma'am, is it a Breaking Bad news?
No, not at all. She is knowing that she is going in the advanced labor. She is having pains from one night. But the outcome you should have told. And these are, I have already told you that all the information I am provided not by anyone, straight from the scorecards or from the TOG articles or from the NICE guidelines, right? So the NICE guideline of the premature, so these are the options that we will discuss with the patient. These are the choices. This is like any concern arise, then we will do the cesarean section. The other is this, we will not do cesarean section, even the concern arise. The third is that if live birth will be there, then we will provide palliative and respect and comfort care to the baby, right? These are the 3 choices. And then delayed cord clamping, level 3 NICU facilities, providing DEXA cover, steroid cover, MEC-sulfate will be discussed with the patient, no tocolysis, right? These are all the patient safety points, and this is the complete station. Now, Dr. Maya, please give me your feedback that how is the station now?
Beautiful. I was just, as I was trying to tell you that only, that as soon as you gave me these 3 options, I remember one day which I attended with the neonatal team, and there was a patient with twin pregnancy, and she was 22 to 23 weeks, if I'm not wrong. And that patient had gone in advanced labor and she was shifted to our hospital. So the neonatal team and the entire consultant and everyone and all the consultant, we had almost 45 minutes to 1 hour discussion with the entire family, and the entire things were given to them in each and every detail, including all the resuscitation, till what level you want to go, whether you want to put the tube for the baby or no, if the case the baby is deteriorating, whether we can put the tube or no. So in detail depth discussion, everything was discussed, and then they have literally taken everything in documentation so that then they will do the things accordingly in theater.
Yes. So, Dr. Maya, now satisfied, happy, station is done?
Absolutely. Very nice. Very good
Thank you
station.
so much. Thank you so much. Deepika, what you want? You want to discuss few more stations, or you want me to say? But we have 10 minutes. Aparna.
This cesarean will be midline or
Ma'am,
transverse?
is it recording?
Yeah. Recording will be uploaded. Don't
Because
worry
I missed
about
the one. No.
Right?
Ma'am,
Okay.
about cesarean, it will be midline or transverse?
Actually, many places it is written like before 28 weeks, it should be midline, right? But
And
I think
second,
so it can be transverse. It should not.
Yeah, it depends actually.
Yeah, and in this station, they're not going to ask about the mode of session, right? It is not about this. This station is all about this, telling the outcome and telling the risk and taking the station forward. You should be knowing how to take the station forward, right?
Dr. Asma, what were the patient safety points in this station?
Yes, patient safety points in this station. Just a minute. Delayed cord clamping. Delayed cord clamping is basically done after 1 minute, right? Patient safety points in this station are basically giving DEXA cover, steroids, right? These are the must if you give. And again, after that, not putting the cerclage and not giving tocolysis, right? And after that, level 3 care, involvement of the neonatologist, right? And telling all the options. These are the basically patient safety points.
Ma'am, but somewhere I have written that the same station that at 5 centimeter tocolysis has no role, but it can be considered to buy time for steroids. So can we say this line?
No, I will not suggest that saying this line, because at 5 centimeter, you are not knowing that she will be delivered in next 1 hour or 2 hours, right? So DEXA is going to have effect. Steroid is going to have an effect, but tocolysis is not recommended in established labor when patient is having regular uterine contractions, right? At this time, it has not got any effect, right? One of my friend has actually told me to discuss one thing, but the friend is not here now. The friend is not here. I have included one thing on her request. She is not here. I'm finding she's not here. Okay, all right. So we will arrange some other session for this. All right, my friends, thank you so much for joining me. Any other question, my dear friends, from these stations that we have done?
Ma'am, one thing I want to say.
Sure. Who is this?
Ma'am, Aparna.
Okay, Aparna, please.
I was too tired today. I thought, no, I'll skip it. Then I heard your voice and it was too contagious. I continued the class. I was too tired today and your voice is really very
So
nice.
the same thing, Dr. Asma. I am post night actually. This was my 4th night. I was feeling so sleepy, and really after hearing your voice and the stations, my sleep has gone.
You know that I'm taking 6-hour session for part 2. Arnav, thank you, my dear. And you know that students are saying we cannot listen recording. We want to listen to you.
Exactly, because
yes,
that
Noha, my dear, it can be done. It is
Yeah.
recommended by talk, my dear Noha. Yeah.
That's really nice.
So thank you so much, my friends, for
So,
staying.
Dr. Asma, whether do you think if I will ask you this straight question that from patient safety perspective, I don't think I will clear the station.
You have given me steroid cover, right? You
But
have
only that much I gave you. I didn't cover the tocolysis part and the other things and all.
See, this is the reason I am here to tell you that how to cover the station completely. I have heard many candidates and they are doing 1/3 of the station, 2/3 of the station. This is the reason I am already telling again and again that taking the right guidance is the zest to pass this exam. Thank you, Noha. Thank you so much. Oh, thank you. Thank you, thank you, thank you. Okay, all right, my friends. So see you next time. Tanya, thank you. Any question? Somebody's calling.
Hafza, your mic is on. Thank you.
I have muted actually, Dr. Maya. All right, thank you participants who have participated so ambitiously and for making this Hafsa, don't scold kids.
Yeah.
I think so. In exam, Ruchi, thank you so much staying with me actually because of exam stress. Now the turn of kids to Hibai, I actually don't know when will be the next session because I want to prepare with the surprises when I will get the stations which are never touched by anyone, then I will definitely get back, right?
Thank you so much, Dr. Asma. That is really, really wonderful.
Thank you so much. Thank you so much. Okay, friends.
It was really
Bye-bye.
wonderful.